Dr. Karl G. Stonecipher, an ophthalmic surgeon and medical director with TLC Eye Centers in Raleigh and Greensboro, North Carolina, has an extensive background as a lecturer, author, and FDA trial contributor in the fields of corneal, cataract, and refractive surgery. In this issue of the VJO, Dr. Stonecipher presents the data and conclusions of a study he conducted on the outcomes and complications of a group of his refractive lensectomy patients over a period spanning 1993 to 2000. Dr. Stonecipher begins by explaining his motivations for the study.
Primarily, I was at Academy this year, and I was with two of my retina colleagues, and we were talking about the surge in refractive lensectomies, and they both looked at me and said, you know, with refractive lensectomy, retinal detachment rates of 8 to 15%, I think that's going to be a real problem. And I looked both at them and I said, you know, I disagree respectfully that the retinal detachment rates are that high. And they said, well, how would you know? And I said, well, I've been doing refractive lensectomy since 1993, and I would like to look at that and prove that to you. So it was kind of a, you know, a discussion, looking at the literature. I looked it up. And between these two retina colleagues, we decided, well, we want at least a 5-year follow-up in these patients. So we want to be at least out 5 years. So I chose from 1993 to 2000 for that reason, and looked at both the myopic and the hyperopic population, because, you know, everybody will say refractive lensectomy in the hyperopic population is probably a safer option. I mean, obviously there's risk of intraocular infection and issues there, but for the most part, you don't have as many issues of retinal detachment. In the hyperopic population. The myopic population with the larger axial links is going to be more of an issue with retinal detachment rates. So in this specific population, we looked at all those three groups and basically felt that, you know, we're going to look at retinal detachments, but the other caveat that they brought up was cystoid macular edema. So I looked at those rates in comparison as well, because I felt that those were the two main complications that you could see after this procedure, and they agreed with that. So pretty much the patient population came from that series from 1993 to 2000, and the refractive error ranged from minus 21.5 all the way up to over 11 diopters of hyperopia. In 1993, you know, a lot of people look at that as a very early start to the refractive lensectomy market, and it's true. But I felt that I didn't really have a good hyperopic option. So in these patients, what I was really doing was electing a procedure that I knew, cataract surgery, offering it to those higher hyperopic patients, and we only had a monofocal lens at this time period, so obviously you're looking at distance vision or you're looking at a monovision type situation, but they were some of the happiest patients I had, and I thought that this would be a group to start with and go to 2000 so that we had enough time, and this was again looking with my retinal colleagues about what they felt would be a comfortable time to report. Now, the population total is 317 patients. Again, the surgery data from 1993 to 2000. The range of spherical equivalent was from minus 21.5 up to 11.5 diopters. So these were all in the days before intraocular contact lenses were available and many of the other modalities that we now use today. The range of cylinder was as high as 6 diopters, and you know, other modalities were used to correct the cylinder, such as limbal relaxing incisions. The range of axial length was 20.28 to 29.7 millimeters, and the range of age was 26 to 80 years. Now, you say, well, an 80-year-old does have some level of nuclear sclerotic changes, but this patient was 20/20 best corrected visual acuity and was looking for an option. And then the range of the intraocular lens was from 4 diopters all the way up to 30 diopters. Now, remember, in this day and age, a lot of we didn't have access to lenses that went to the levels they do. So some of these patients received piggyback intraocular lenses to create and correct their full refractive error. Now, in the series, best corrected visual acuity had to be at least 20/40 preoperatively. That was just my definition. And you've got to realize that amblyopia did exist in a number of the patients in this population because of their severe refractive error. But they didn't have cataracts, but some of them did have worse vision. And patients, you know, were excluded from the group if they had any preoperative systemic pathology, corneal pathology, and or any age-related macular disease existed. So the literature supports about an 8 to 15% retinal detachment rate, but with modern phacoemulsification equipment and with clear corneal incisions, you know, I felt that this was a good procedure. And so that's what techniques were used starting in 1993. And like I said, any retinal pathology in these patients, what I think was done different were that I had them seen by my retina specialist. So they got an independent evaluation by one of two specialists in my practice, and then if they needed it, they were appropriately treated. I think that the implications are that we can better educate our patients and our retina colleagues about what the true retinal detachment rates are with modern phacoemulsification techniques. I also believe that we can educate our refractive surgeons and our refractive cataract surgeons specifically that have a low threshold to refer these patients into a retinal practice that you trust and know. A large majority of these patients I saw were referred to a retina specialist, and that was roughly around 4.5% to 5%. Of those patients that referred, 57% of them were treated in some format, and that was specifically mainly the myopic population, that they were doing peripheral laser for small little holes or tears in the periphery, and then we would wait the appropriate time, which was usually 6 months after the laser before any surgical procedures were done, and that the retina colleague had said, you know, that's appropriate and they can now undergo surgery. So in the refractive error, we have myopia accounting for 65%, hyperopia is 33%, and 2 were emmetropic. And the preoperative uncorrected visual acuity was in roughly the 20/150 range, and the postoperative uncorrected visual acuity was hovering around 20/30-ish, or a little bit better than 20/30-ish postoperatively. Now, this is one of my favorite slides to show that, yeah, these patients did get better, and we did see some of these amblyopic eyes gaining lines of vision. So looking at the preoperative best corrected visual acuity versus a postoperative best corrected visual acuity, I would say that that was arguably related to the fact that many of the amblyopic patients actually gained lines of vision. Now, someone may argue that they really had a cataract or they had a small cataract and you were just treating the cataract, but these patients I specifically looked at were not, and were not in the cataractus population. Now, preoperative best corrected visual acuity versus postoperative uncorrected visual acuity is kind of our yardstick. It's what the patients saw before surgery in their glasses or contact lenses versus what they saw postoperatively. The most exciting thing about this is twofold. To be included in the study, you had to have a level of vision that I classified as 20/40 or better. And again, I talked to the retina colleagues and we kind of polled what kind of series that we wanted to look at because a large majority of these patients have a degree of amblyopia. So the patients may be 20/30, you know, 20/40, but not have any lens pathology. And in this group, none of them had lens pathology. And so that was the important point. So I looked at the healthy population of people and decided that we're gonna look at a certain level of visual acuity. Now, the most exciting point in that amblyopic population is a lot of those guys gained lines of vision. So they went from 20/40 to 20/30 or 20/20, and somebody might argue that, oh, they had nuclear sclerotic changes, but I mean, this was even in the young individuals that were 26, 27 years of age. So we saw an increase in their uncorrected and best corrected vision, and really the most exciting thing to this group was what they saw in their glasses or contact lenses was equal to or a little bit better than what they saw postoperatively uncorrected. And you take somebody that's got 11 diopters or more of refractive error, whether that's farsightedness or nearsightedness, and allow them to see it. They're pretty excited. It's a good group. Now, YAG lasers accounted for roughly about a third or a little more than a third of the patient population, and the literature supports a YAG laser rate of around 10% with modern surgical techniques and technology. But literature at this time period that we're looking at specifically from 1993 to 2000 supports a rate of around 33%, which was pretty much the same. Now, the hyperopes showed much lower levels, and I'm not quite sure of the etiology for that other than the way in which the lens sit in the posterior chamber. Specifically, one of the issues that we also need to discuss is what else could cause problems. Well, postoperatively, we saw higher incidence of YAG capsulotomies in the entire group of the myopic patients, and that was roughly around the mid 40% range, is around 46%. And the hyperopic range was actually fairly low. It was lower than the overall group, which was at 36%. Now, the reason I worry about YAG capsulotomies is because, two of the risks of YAG capsulotomies are retinal detachment and cystoid macular edema. So I wanted to capture that. So then when I looked at the literature, I found that was a pretty comparable rate, that about 1 out of 3 patients actually get a YAG capsulotomy from 1993 to 2000 in this group we're talking about in cataract surgery. But with modern techniques, modern intraocular lenses, the retinal detachment rates are more around the 10 to 12% level. So I didn't see an increase, is where I'm going, in any of the patients that had gotten a YAG capsulotomy. So I didn't see that a YAG capsulotomy produced cystoid macular edema. I didn't see that it produced a retinal detachment in anybody in this series.
Are there any considerations with the age of the patient being a predisposition for detachment?
Do we see more of a problem in the older patient population versus this younger patient population? And that was the argument. The argument with this group was that the myopic younger patients are going to have a higher retinal detachment rate. And we didn't see that. In fact, we saw a very low rate of retinal detachment. And again, the younger population aggressively healing were more likely to develop CME, and we didn't see that as well, too. Now, we're aggressive with treatment. I used a steroid and antibiotic for 2 weeks post-operatively, 4 times a day. Non-steroidal use was not an issue during this time period, circa around cataract surgery, but in my refractive lensectomies today, I do tend to add a non-steroidal in this patient population. So my summation slide is, I'd like to look at the bottom. 57% of this patient population was referred to a retina specialist. I had a very low threshold to refer these patients. So if I saw any peripheral retinal abnormalities, and we're probably talking more about the myopic patient population than the hyperopic group, but if they had any kind of pathology, they were immediately referred. And of those that were referred, we had 57% of them treated. So we basically referred 4.5% of the patients to a retina specialist, but a large majority of those patients that were actually there actually received a laser of a retinal hole or retinal tear or retinal abnormality. And that accounted for about 2.6% of all the eyes. Now, the 2 most important findings, and this was the original point of my study, was CME rates and retinal detachment rates. And really, the CME rate was 0.6%, and all those were treated without any sequelae to their best corrected visual acuity. And we had 0.3% as a retinal detachment rate. So what I'm trying to point out with this study is that I think that patient can be adequately educated in a day and time of 2008 that the risk of retinal detachment is much less than what the literature is supporting. Now, one of the things that I looked at with this group is I wanted to see how this group fared in relationship to my LASIK volume. And I was looking basically at my practice trends, and my practice trends of today was that my LASIK volume numbers, the people are getting younger, and more of the baby boomers and the older patient populations are now choosing refractive lensectomy because they have the option of a presbyopic treatment as well. So I think that, we're talking about LASIK volume trends. We're down for 2007 slightly, and I think some of this may account to the fact that aging boomers have significantly affected this, and that the myopic procedures are decreasing as they age out of this LASIK range, and the hyperopic procedures are increasing as the boomers' hyperopia manifests, or their latent hyperopia manifests. And the Gen Xers and the millennials are aging into this myopic LASIK population, and I think you're going to see more and more of this segment coming into LASIK, and I think you're going to see more and more of the older patient population, specifically the baby boomers, trending towards a refractive lensectomy option. And I'm finding that more and more my hyperopic LASIK market is dwindling because I'm referring more of those patients to the refractive lensectomy as an option in my baby boomer population, or my older patient population. And my marketing trends are geared towards the Gen Xers and the millennials, or the younger patient population. And I think, this may be unique to me, but we've also looked at a large series of practice patterns with Dr. Kazarian and his data link group, and we're seeing similar findings across the United States. So I think it's important to track your demographics, look at your practice, see what's happening over the course of the year, and then you can compare your demographics to the community. And there are variations that exist, but I think for the most part, see if you're seeing the same trend.